So thank you very much for the invitation to talk about pelvic floor muscle training versus surgery for pelvic organ prolapse. And I'm going to concentrate on the pelvic floor muscle training. So why should we do pelvic floor muscle training? This statement was from Arnold Kegel back in 1952. He stated that with adequate pelvic floor muscle training, the woman learns to maintain the perineum, bladder, and uterus in a higher position. The slack in the supportive muscles will be taken up, and the vagina will become longer and tighter. Of course, today we have more sophisticated theories about what's going to happen if we do strengthening of the pelvic floor muscles. We are working to improve the structural support of the pelvic floor and the organs. We are doing this by trying to lift the anatomical location of the pelvic floor, to hypertrophy the pelvic floor muscles, to close the levator hiatus, and to create a certain stiffness in the connective tissue within and surrounding the pelvic floor muscles. Today, there are 10 randomized controlled trials of pelvic floor muscle training for pelvic organ prolapse. And you can see that this research area started up in 2000, so this is a new area. The results of these trials are that they can lift the prolapse one stage. And all studies have shown improved symptoms of pelvic organ prolapse. There is also effect on comorbidity of the studies. And very important, there are no complications or side effects of pelvic floor muscle training to the woman as a whole. We were eager to find out if it was possible to strengthen the pelvic floor muscles in women with pelvic organ prolapse. So there are few studies that have addressed this question, but we did that and presented that in 2010 because this has to do with the morphology of what is happening when we are doing pelvic floor muscle strength training. And we found that there was a tremendous increase in pelvic floor muscle strength compared to the untreated control group. The effect size is 1.2. And the same with pelvic floor muscle endurance. As you can see here in this picture, that we are also measuring this for 10-second holding period, and we are measuring the area under the curve, and again, a huge effect size between the control group and the pelvic floor muscle training group. We also looked at morphological changes using 3D and 4D ultrasonography, and this was a randomized control trial on 109 women. And we are looking at the differences between exercise and control, which is the purpose of having a control group. We showed that there was an increase in muscle thickness of 15.6%, which is the same as you are achieving when you are training, for instance, your biceps. There was a reduction significant between the groups of 6.3% in the hiatal area and also for muscle length. And very importantly, we permanently lifted the position of the bladder neck with 4.3 millimeters and the rectal ampulla with 6.7 millimeters. And in addition to that, we found that there was a reduced hiatal area and muscle length during Valsalva, and this may indicate an increased pelvic floor muscle stiffness. So these are morphological changes happening when we are doing intensive pelvic floor muscle training for women with pelvic organ prolapse. The exercise protocols in these 10 studies are quite similar because the mode of exercise is always strength training of the pelvic floor muscles. In most studies, individual physiotherapy has been conducted, so very few group training programs in pelvic organ prolapse. The frequency had been once a week with the physiotherapist, and then, in addition, home exercise. The intensity in all studies have been close to maximum contraction, and the duration varies a lot, between 3.5 months and up to 6 months of exercise. And of course, adherence to the program is very important to achieve effect, and there is variation in adherence, but it's generally high in these studies. So the treatment options should follow this evidence-based practice model, and the different options we have for pelvic organ prolapse today is also watchful waiting. This is a study from Sweden where they were doing watchful waiting in women with pelvic organ prolapse for 4 years. And they found that 47% had unchanged POP-Q stage, and 40% had regression. This was very surprisingly. And then 13% only had a progression. So wait and see is also something that we should consider, especially before surgery. Pessary, the level of evidence is only 2B, and this is because it's not been compared with no treatment or compared with surgery alone. Surgery, there has only been studies comparing different surgical methods. So there are no studies looking at watchful waiting and surgery or pelvic floor muscle training and surgery. And the level of evidence is not that good. It varies between 1 to 4 and A and D. When it comes to pelvic floor muscle training, the level of evidence today is 1A. So what about the long-term effect? There are very few studies, of course, in this area. And this is a 2-year follow-up of pelvic floor muscle training for pelvic organ prolapse from the UK. And this is a follow-up of a multi-center single-blind RCT. The outcome was pelvic organ prolapse symptom score, and also if the patients had had further treatment. 40% only responded, so this is a limitation of the study. And they didn't find any significant difference between the groups in POP-SS. However, there was a significant difference between further treatment in favor of pelvic floor muscle training, both in general and also in those who had surgery or not. And then the big question is also, should we do physiotherapy in conjunction with reconstructive surgery for pelvic organ prolapse? There are, again, few trials in this, but this study from 2013, Pauls and co-workers, looked at 49 women who were randomized to physiotherapy for 2 weeks preoperatively, and then 2, 4, 6, and 8 to 12 weeks postoperatively, compared to standard care. And the outcome was quality of life, POP-Q, and surface EMG. The results found no significant differences between groups except for surface EMG in favor of the physiotherapy group. And the optimal randomized trial from Barber in the US in 2014, also a RCT of 374 women undergoing surgery for both apical vaginal pelvic organ prolapse and stress urinary incontinence. 186 women had pelvic floor muscle training and 188 usual care. This was also a 2-year follow-up, and they had high follow-up rate in this trial. Pelvic floor muscle training was individual visits, 2 to 4 weeks before surgery, and then 4 post-operative visits. It's not really well explained whether there were physiotherapists who conducted these exercises, and we do not know much about the program. This is really not very well described in the article. And they used the Brink score, so it was only palpation when it comes to pelvic floor muscle strength. However, the result showed no association with greater improvement in UI score at 6 months, POP scores, or anatomic success at 24 months. And there were no difference between groups in the Brink score. So these 2 trials together does not support to give pelvic floor muscle training in conjunction with surgery. The adherence was high, so that cannot explain why it was not working. However, what about prevention? Albert Einstein said, "Intellectuals solve problems, geniuses prevent them." And I think it's very important that we try to prevent conditions like this. But on the other hand, I don't think that physiotherapy could treat a condition when it has come this far. So we have to start much earlier than at this stage. There is only 1 trial so far on prevention, and this is secondary prevention for pelvic organ prolapse. 407 women with a median parity of 2, and they were not seeking treatment for the condition. However, when they were evaluated, they had POP stage 1 to 3. Therefore, this is not the primary prevention program, but it is a secondary. And they had a 2-year follow-up. They used the same pelvic organ symptom score, and they randomized the participants to lifestyle advice leaflet in 1 group, and then 5 physiotherapy appointments over 16 weeks, plus 2 6 weeks blocks of once a week Pilates classes, and these classes included specific pelvic floor muscle training. The results show that it was in favor of the pelvic floor muscle training group, the results. So this is in favor of that it is possible to prevent development of pelvic organ prolapse. What about primary prevention? Actually, there are no studies so far on that, and I think personally it's unlikely that we have ongoing high-quality RCTs for 20 to 30 years, which is what we need. So in the meantime, we need to look at differences that has been found in case control studies showing that there is a difference in pelvic floor muscle function in women without prolapse compared to those with prolapse, and that we also found significant and clinically relevant morphological changes after pelvic floor muscle training in women with pelvic organ prolapse. This is theoretically showing that it is maybe possible to prevent, but we don't have the data so far. So is this enough to implement? Actually, it's not, but based on the theory, it may be possible to think that it is a way to go. So why should we do conservative treatment? Well, pelvic surgery is a risk factor for pelvic organ prolapse. We all know that from different studies. And there are devastating complications after POP surgery, especially after mesh. And we don't have to repeat all these complications because they are well known. And also, there are 30 to 58% need for reoperations after POP surgery. So it's not effective as it is. So when it comes to concluding on pelvic floor muscle training for pelvic organ prolapse, this is a new area of research, and of course we need more studies, for instance, in connection with surgery and also as a preventive issue. However, the theory and 10 high-quality RCTs and systematic reviews support pelvic floor muscle training in treatment of pelvic organ prolapse. There is, of course, as in every exercise science area, a dose-response issue. There are differences between these trials when we're comparing the number of contractions, the intensity of the contractions, and the length of the exercise period. However, there are no adverse effects or complications reported in this trial, so I think this is what we should aim for. And I would say on behalf of maybe most women who are informed of these surgical treatments that don't mesh with me. There are no studies on primary prevention, but we may think that to enhance lifelong physical activity and also pelvic floor muscle training may be a good idea to avoid obesity and also to avoid constipation and straining. These are just suggestions. Thank you so much for your attention.